Thank you, chairpersons. Thank you, Dr. Kumarvel and team for this opportunity. For the next 20 minutes, I'm going to discuss about what intensive care endocrinology and how we can simplify and treat this patient. So we, as an endocrinologist, not only write prescriptions and examine, and we too see emergency cases. So both excess and also defective hormones can lead to a crisis in our patient. And these crises are have a higher mortality, almost in thyrotoxicosis crisis, almost 90% mortality, also in patient with hypothyroid coma. It also causes increased morbidity. So early clinical diagnosis and treatment is very important in this type of conditions. So I'll start with this patients. We know that this patient, 15-year-old, coming with nausea, vomiting, and rapid breathing, and then over a period of time, the patient became drowsiness. So contrary to the type 2 diabetes mellitus, the parents exactly know what day the diabetes have developed. It starts with 10 days before he had polyuria and polydipsia. Most of parents will come with this history, but some, they ignore that. They come to ICU with history of drowsiness and then polyuria and this thing. So clinically, it is consistent with type 1 diabetes. Blood sugar is elevated, creatinine is elevated, suggesting a pre-renal thing. Patient have an acidosis and also a high anion gap thing. So in patient with diabetes mellitus, we can have two types of emergencies. Particularly, we can have ketoacidosis or hyperosmolar state. Both of them are extension of the same clinical conditions. When you have an absolute insulin deficiency, then they present with diabetic ketoacidosis, which develop sometimes within hours or within days. So if the patient have a severe insulin deficiency, but not an absolute, then they have a shortening of the pathophysiology and they present with hyperosmolar state, as Dr. Adeline has described. So the pathophysiology is unchecked gluconeogenesis leads to hyperglycemia, osmotic diuresis and dehydration, and this unchecked ketosis leads to ketone body formation that in turn dissociate to form the hydroxyl ions and ketoacidosis. So it is important to find out what are the important things in the management of diabetic ketoacidosis. There are 5 important points to be remembered. One is fluid. It was estimated that around 5 to 7 liters of fluid has been lost in patient with diabetic ketoacidosis. We have to correct it. Second will be the insulin therapy. Third will be the acid-base balance. Fourth will be the electrolytes. We'll see one by one. As far as the fluid is concerned, the replacement depends upon the volume status of the patient. So usually these patients have a severe dehydration. We have to correct at least 1 to 2 liter within first 2 hours, and followed by we need to correct the rest of the fluid deficit over 24 to 48 hours. Start with normal saline, and when the sugars reaches around 200, we can change to dextrose normal saline and continue the insulin infusion. Stopping the insulin will cause a rebound ketosis and should not be done. Second, the insulin replacement. The insulin, particularly short-acting insulin or regular insulin, give a bolus of around 0.1 to 0.3 units per kg, around 6 to 10 units as a bolus, followed by an infusion of 0.1 unit per kg. And if the blood sugar is not coming down within 1 hour, more than 10% reduction, give another bolus and continue that one. And third thing, don't stop the insulin or continue the insulin, change the infusion to dextrose normal saline, and then continue the insulin infusion till the patient acidosis get corrected. And the other important thing is potassium. I think all patients with diabetic ketoacidosis, we should monitor serially the potassium. So we know that insulin actually shifts the potassium from intravascular to intracellular. That happens, means when there is a lack of insulin, this shift happens in the opposite direction. So even when the patient have a normal potassium value, we need to start potassium in this patient. So if the potassium is 3.3 to 5.2, give at least 20 to 30 milliequivalents of potassium in each pint of normal saline. If the potassium is less than 3.3, hold on the insulin, correct the potassium, and then start the insulin afterwards. If the potassium is 5.2, monitor serially and depending upon the renal function, we can correct that one. Bicarbonate is not always necessary unless the patient have a severe acidosis of less than 6.9, or if the bicarbonate is less than 15. Correct with 4 ampules to 5 ampules in 1 pint of normal saline over 2 to 4 hours, recheck the bicarbonate, and then depending upon your correction, you can continue that one. And these are the important points to be considered. The first line of management in diabetic ketoacidosis is fluid resuscitation, not correction of hyperglycemia. The primary role of insulin sensation is DKA, is to correct acidosis, not to control the blood sugar. And the blood sugar should be corrected gradually, not abruptly. And bicarbonate is not necessary in most of the patient. Be cautious in fluid resuscitation in patients very young or very elderly. We should look for heart failure and avoid potassium in the initial liter, sometimes which can lead to dehydration and AKI. So the pitfalls include, we sometimes never assess the underlying pathophysiology which caused that one. Patient may have an infection or MI, which has to be adequately monitored. We move on to the second case. This patient is a 72-year-old gentleman admitted with bronchopneumonia. He was progressing well, but suddenly on 4th day of the therapy, the patient went in for a seizure and became disoriented. I think thanks for Adeline to present the hypernatremia case. So she stick on to hypernatremia. So her oxygen saturation was normal, and the investigation shows this patient has a sodium of 115. And this patient's medication include augmentin, paracetamol, and omeprazole. So the clear reason for this disorientation in this patient is an acute onset hyponatremia. So hyponatremia is the most common electrolyte imbalance in an hospital setting, and the prevalence vary depending upon what level you consider. The prevalence is very high when we consider 135 as normal, but come down to 1 to 4% when it is less than 130. It can be defined as an acute or chronic, or it could be defined as a mild, moderate, or severe when depending upon the level of sodium. The 3 important steps of investigating hyponatremia is to first do a urine and serum osmolality, check urine spot sodium and uric acid, and then do a thyroid and cortisol. So this will give a clue whether this patient is having a real hyponatremia or pseudo-hyponatremia, what is the volume status, and what is the urine osmolality or urine sodium will give what is the reason for hypovolemia in this patient. Start with urine osmolality. So normally we get a low osmolality hyponatremia. When they have on other extremes, think of a pseudo-hyponatremia. Particularly these things are not common unless when the sample was taken immediately after mannitol, sometimes they may have a high osmolality hyponatremia. So look for the volume status, easily done. When the patient has pedal edema and elevated JVP, look for heart failure, liver disease, and nephrotic syndrome. If they have a hypovolemia, dry tongue and dehydration, check the urine spot sodium. If it is very low, look for dehydration and diarrhea. If it is more than that, I think we should rule out diuretics, AC inhibitors, and other conditions such as cerebral salt wasting. So our patient was diagnosed with SADH. It was ruled out to have cortisol deficiency and hypothyroidism, and this is what the Barter's criteria say to know what is SADH: decreased serum osmolality, inappropriately normal urine osmolality, and then euvolemic status, and rule out all other precipitating factors for hyponatremia. And if this is there, this patient is having an SADH. So there are multiple causes for SADH. Want of time not going into this one. Neoplastic, pulmonary, CNS, and drugs. I think both drugs and other conditions should be monitored in this patient. In this patient, these patients have a pneumonia, and if you see, almost most of the drugs can cause this condition SADH. If you see, even simple drugs such as the tricyclic antidepressant, anti-diabetic drugs such as glipizide, and anticonvulsants can cause SADH, and in our patient, the patient is taking omeprazole. So the treatment in a patient who are acute sick like seizure and other thing, we can give an IV bolus. I never give IV bolus, but when a patient is comatose or having seizure, throwing seizure, we can give a bolus of 3% saline, 100 ml, slowly over 10 to 20 minutes. Depending upon the clinical conditions, then we can change to a continuous infusion. So I usually give a 3% saline, 50 ml per hour for at least 6 hours, so that 300 ml would have passed, and then we can clinically and also biochemically assess and follow the treatment. So important to identify what is the type of hyponatremia and investigate and come to conclusion this is the reason for that one, and as Dr. Adeline mentioned, we should not overcorrect hyponatremia. Any chronic we should correct only by 8, and acute we can go up to 12 millimoles per liter. In patients who have a chronic hyponatremia, a mere fluid restriction and increased salt intake, sometimes avaptins can help to overcome the hyponatremia. This is our third patient. I think this patient was endocrine consult was given in a patient who admitted with polytrauma, but the patient was drowsy. So they have done a TSH and they found that it is normal, but free T3, free T was low. So what is the diagnosis? This patient has no previous history of thyroid illness. So should we start treating this patient, or should we wait and watch, or should we analyze the anti-TPO whether to look for this thing? So the closest differential diagnosis in this patient is have a central hypothyroidism. But what is this patient is having is a non-thyroid illness syndrome, or what we call it as the sick euthyroid status. So a sick euthyroid status is common in patients who are very sick, and it is a natural physiological mechanism that help to conserve the energy for our patient. If you see, immediately when the patient becomes sick, the T3 comes down and the RT3 increases. This indicates that the body is conserving the energy, and followed by T4 and TSH. So any patient who was sick, the first thing is to not to check the thyroid function unless the pretest probability is high, and if it is low, we should rule out central causes. We can do an FSH in a female or something. If it in a postmenopausal, if it is low, then we should suspect the other thing. But most of the time, it will be in a very sick patient, it would be a non-thyroid illness syndrome. We should also remember that various drugs can affect the thyroid hormone synthesis, TSH release or conversion should be taken into consideration. So patient with non-thyroid illness syndrome, no need for any treatment. It is an adaptive mechanism of body to conserve energy. Routine thyroid function test is not necessary when the pretest probability is normal, and there is no evidence-based consensus or guidelines advocates treatment for this patient. We move on to this fourth patient. For want of time, I'm just moving rapidly with the history. So this patient is on anti-thyroid medication, comes to the casualty with fever and elevated JVP with a heart rate of 120. So naturally, when we see we don't have an oral anti-thyroid medication, we consider this patient as a fever with sepsis or other thing. But if the patient gives history of a default of oral anti-thyroid medication, the first thing to come into our mind is a thyrotoxic storm. Okay? So investigation proves that this patient have a thyrotoxicosis, renal function is normal, SGOT-PT is elevated, bilirubin is slightly elevated, ECG shows a rapid ventricular rate with atrial fibrillation. The diagnosis is thyroid storm. So thyroid storm is a clinical diagnosis. We should start treating this patient even before the reports have come. It is invariably fatal if untreated, and it can be. No one knows why some patients develop thyrotoxic crisis, but there are several precipitating factors which can lead to thyrotoxic storm, which includes sepsis, surgery, radioactive iodine treatment. After 2-3 weeks, they come back with thyroid storm. Even a vigorous palpation of the enlarged gland itself can precipitate a thyroid storm. So as I mentioned, it is clinical diagnosis. The Bruce-Schwarzkopf score is used. The 6 parameters have been used: temperature, CNS, GI, heart rate, heart failure, and precipitating factor. Any value less than 25 unlikely represent a storm, and anything more than 45 highly suggestive of storm. So treatment is start with supportive measures, temperature control and fluid resuscitation, and then PTU is the drug of choice because it prevents the conversion of T4 to T3 in the periphery, and we should give a loading dose of almost 500 milligrams and then followed by 250 milligram every 4th hourly. Followed by, if available, we can give a Lugol's iodine or a saturated solution of potassium iodide, but it should be given 1 hour after starting the propyltyrosol because it can further increase the hormone synthesis. Beta blockers are mainstay to prevent the adrenergic overactivity. Very high dose, 40 to 80 milligram, 4th hourly can be given. And then hydrocortisone, steroids tend to prevent the conversion of the T3 to T4 to T3, and also it impair the release of thyroid hormones from the thing. So we should address the underlying causes also. Very rarely we may need a plasmapheresis or dialysis in type of patient. Moving on to the fifth patient. This is a patient who came with history of hip fracture. Surgery was done, but on the fourth post-operative day, the patient gone for a hypotension and disorientation. The endocrine consultation was done because they were done investigated for causes of this drowsiness, and they found that this patient is having a hyponatremia, an elevated potassium, and the random cortisol was 10 micrograms per deciliter. So, as Dr. Valaidam sir mentioned, when a condition where the response of the cortisol is high, should be high, even if it is normal, we should consider a hypocortisolemia. So, in this condition where hyponatremia and this thing, the response should be more than 19 micrograms, but it is inappropriately normal. So, on further history, this patient says that this patient takes medicine from outside for her skin conditions, and it invariably found to have a beta-methasone in the night, what patient was taking. So, it was diagnosed to have an exogenous steroid-induced HP axis suppression. The gold standard treatment for treating patient with hypercortisolemic crisis is hydrocortisone. We start with 100 milligram IV stat followed by a 50 milligram Eithavali for 24 hours. And then we can follow these patients. So an important thing, whenever patient is on steroids, never stop the steroids. Get the amount of steroid what the patient is taking, convert into prednisolone or hydrocortisone, and then try to gradually taper it and never stop it. And if the patient is taking for a very long time, sometimes stopping may give more harm to the patients rather than continuing it. So patients more than 1 or 2 years, we may not able to stop it permanently. We may need to give a replacement dose of steroids, like 5 milligram once daily of prednisolone can be given. This is my last case. This is a 55-year-old patient admitted in ICU with loss of consciousness. So this patient have an inappropriately lower consciousness to her the CT scan finding. So initially they done a CT scan for unconsciousness. They found that this patient have a subcortical infarct. But this patient on evaluation found to have a hypotension, bradycardia and hypothermia, suggesting that this patient may have a hypothyroid coma. So when the history was taken, this patient was taking thyroid medicines but have very poor compliance. So if you see patients who have very poor compliance of both hyper and hypothyroid may present with these type of complications, and we should explain them regarding these complications. So as I already mentioned, it has very high mortality rate, almost 70 to 80% of mortality. So immediate treatment should be started. Don't wait for the biochemical results to come. Based on the clinical suspicion itself, we need to start the treatment. And then first and important thing is to secure the airway, because these patients have a reduced respiratory drive and also have a macroglossia. So when you see the saturation, it will be dropping when you think. So immediately go for either a non-invasive or invasive ventilation and secure the airway. Second thing is to give a passive rewarming. Never go for an active rewarming, because that can cause cutaneous vasodilatation and leads to an hypertension. Steroids helps to improve the condition. The reason why steroid given in this condition is that in a patient with severe hypothyroidism, they have a relative cortisol deficiency. When we start a higher dose of thyroid hormones, this patient may have a circulatory collapse. We can give hydrocortisone 100 milligram Eithavali, and then followed by several days to prevent the relative cortisol deficiency. So in patients who have hypothyroid coma, the IV preparation is preferred. Unfortunately, we don't get these preparations frequently. Even in Coimbatore, we have only one center and it is available rarely. But if it is available, we should give a loading dose of 200 to 400 micrograms IV stat, followed by 100 milligrams twice daily for 2-3 days, and then 100 milligram once daily. If T3 is available, now I think we have T3 tablets are available, but IV T3 is available, which should be given cautiously, because it actually increases the thyroid hormones much more faster, can lead to arrhythmias and other thing. If available, 5 to 20 micrograms can be given twice daily or thrice daily, and then we can taper and stop that one. And then these patients tend to develop hypoglycemia and hyponatremia. And the important thing is in hyponatremia, we need not correct the hyponatremia. Treating the thyroid itself can actually make the thyroid, the hyponatremia normal, because when the patient, we start thyroid hormones, they tend to lose the free fluid and they develop that one. So if the patient has hypertension, then probably we need to fluid replacement and vasopressor supplements. So endocrine emergencies are not uncommon, but if it happen, they are very severe and they tend to have a higher mortality. We should be clinically diagnosed before the biochemical reports have come, because delaying the treatment for 6 to 8 hours sometimes actually have a deleterious effect in terms of outcome. And if the patients who are on these chronic medications, the importance of these complications should be explained. Thank you.